Hi, this is Brian Warmers, and I'm going to be talking about biliary system and pancreatitis today for medical surgical nursing. Some of our main learning objectives with this are going to be talking about cholecystitis and pancreatitis, and then understand the Whipple procedure and the indications for a Whipple procedure. So cholecystitis is inflammation of the gallbladder. This can be with stones, with gallstones, or without stones. And so it's calculus cholecystitis, cholelithiasis, or acalculous cholecystitis. Just rolls off the tongue, doesn't it? With these gallbladder wall may be perforated, and peritonitis will occur if it is. This is thought to be the result of abnormal cholesterol and bile salts. The way that the patients will present will include jaundice, icterus, pruritus, which is itching, flatulence, dyspepsia, belching, anorexia, nausea, vomiting, abdominal pain, especially shortly after eating fatty foods. They can have some biliary colic, and that's pain when the stone is moving through that duct. And as a result of that, then they can have tachycardia, pallor, and diaphoresis. Very common to have Murphy sign, which is pain increases with deep inspiration, or a Bloomberg sign, which is rebound tenderness. So you push down on the abdomen, and that doesn't hurt, but when you let go, then it hurts. And then, of course, they can have steatorrhea, which is related to their stools, and you're seeing fat in the stools. So cholecystitis, some of the main things that we can do for this would be nutritional therapy, so a low-fat diet with fat-soluble vitamins and bile salts. We can do drug therapy, so controlling pain with morphine or hydromorphone, and then, of course, anticholinergic drugs, and finally, antiemetics if they're having nausea and vomiting. We can treat this with extracorporeal shockwave lithotripsy, so this is when they sit into a big tank of water and we use shock waves and break up the stones within that body. Just be aware that hurts, but it's an effective non-surgical management of this. Otherwise, we can go in and hopefully we can put a catheter in, so percutaneous, so through the skin, transhepatic, so through the duct system, and then find that blocked area and then remove the stone. And then finally, if those aren't working, then of course we can do open surgery and go after it that way. So we talked about pancreatitis briefly with that previous topic, but what pancreatitis is it's a very serious and life-threatening inflammatory process of the pancreas. The bad thing about this is that the enzymes are usually activated in the pancreas, but they should be in the intestine. And so those enzymes are used to breaking things down, and that leads to a lot of necrotizing, and that can lead to blood and lots of problems that way. So the four processes are hallmark pancreatitis necrosis include lipolysis, so the release of fatty acids, proteinolysis, splitting of protein, necrosis of blood vessels, which is going to result in bleeding, and then inflammation with the white blood cell clusters. So symptoms tend to be worsened with alcohol or fatty food ingestion, but it's going to vary widely. It can include jaundice, Cullen sign, which is bruising around the umbilicus if there's internal blood, Turner sign, which is bruising around the flanks around the kidneys. Bowel sounds might be decreased, abdominal tenderness, a rigid board-like abdomen. Anytime you hear the terms rigid board-like abdomen, make sure that that's a very concerning finding and make sure you pay attention to that. That is something that the provider should know about rather quickly. They may have some nausea, vomiting, pancreatic ascites, changes in vital signs. Oftentimes we will do labs including glucose and liver enzymes related to the pancreas. For this, ways that we manage it will be managing the pain. So of course, comfort measures to reduce the pain. We're going to decrease the GI tract activity, decrease pancreatic stimulation. So try not to, we might give them a little break from eating for a little bit. Treat with IV fluids for hydration. Gastric decompression, so put a nasal gastric tube down and pull out some of the free air. And then, of course, pain management with some opioids. And so with this one, Dilaudid is your best bet. The morphine has been shown to cause some spasms at the sphincter of Oddi, which I'm not expecting you to know what that is, but just realize that dilaata is probably the choice on this one. If it continues, ERCP, so this is endoscopic, so we're taking a tube and going up and going into that biliary tree and trying to figure out where this is at. And if it's a cause like by gallstones or the sphincter is too tight, we can fix those things. If that doesn't work on ERCP, we can do surgical intervention. Finally, the Whipple procedure. So this is a pancreatic duodenectomy. And basically, we're taking the proximal head off of the pancreas, the duodenum, and portions of the jejunum, the stomach and the gallbladder, with anastomosis of the pancreatic duct, common bile duct, and the stomach. So what we're doing is we're cutting and then we're pasting. So we're using basically the jejunum as the tube to connect your gallbladder, your pancreas, and your stomach. And so we're just kind of cutting, rearranging a few things. And oftentimes, we'll use this for biliary obstruction. And that will conclude this lecture. If you have any questions on the list, please feel free to contact me or your instructor for the course.